It's a huge pleasure to welcome so many of you to this first webinar in the 2025 European Academy of Pediatrics webinar series. I'm Bertolt Kolecko. I'm a pediatrician at the University of Munich in Germany, and I have the privilege to serve as the president of the European Academy of Pediatrics. And in this role, I'm truly excited that we are starting now a regular series of webinar events which will be advertised on our website and our newsletter. So I hope you will not only be happy about today's event, but will stay tuned for the next topics to come. And I can already announce that we'll have our next webinar in 1 month from now at May 15 at the same time, 1800 hours CET, and it will be on alcohol. I'll come back to that at the end of this session. In this webinar, we hope to get a lot of questions and comments from you. And if you go to the bottom of your screen, you see a question and answer box. So I encourage you to use that any moment already during the presentations and write down your questions and comments, and we'll try to address as many as possible. Today's session is attacking a really important topic. It brings critical attention to the global resurgence of vaccine-preventable diseases, specifically measles and pertussis, and explores the urgent need for stronger immunization strategies and vaccine advocacy. We are truly honored to be joined by two very distinguished speakers whose expertise lies at the intersection of pediatrics, infectious diseases, and public health policy. Our first speaker is going to be Associate Professor Hans-Jürgen Dornbusch. He's a leading pediatric infectious disease expert at the Medical University of Graz in Austria, and he also works in pediatric primary care, so he sees all the aspects of pediatric care. He is the chair of the European Academy of Pediatrics Vaccination Strategic Advisory Group, and I'm really grateful to you, Hans, for leading this important activity. He's also head of the Vaccination Board of the Austrian Society of Pediatrics and Adolescent Medicine. His work focuses on early detection of infectious complications in immunocompromised children and on advancing evidence-based vaccination strategies. Following then is our second speaker, Professor Zoe Dorothea Pana. She's professor in pediatrics and epidemiology at the University of Nicosia Medical School in Cyprus. She has extensive training in hospital epidemiology and antimicrobial stewardship from Johns Hopkins Hospital, and she's also a recognized leader in infection control, vaccine research, and European policy guidance. She serves on numerous scientific boards, including ESPID, ESCMID, and ECMM. She has contributed to over 80 peer-reviewed publications, and she's also been very actively involved in the European Academy of Pediatrics. So without further ado, I'll hand over to you, Hans-Jürgen, on measles. And again, don't forget to write down your questions in the Q&A box.
So thank you very much, Bert, for this nice introduction. I just bumped into the topic with a short review of the history of measles. It's not well known that measles is probably of a zoonotic origin and is derived from the winter pest, which is causes disease in hoofed animals. And it was even in the 4th century before Christ that first evidence of sporadic human infections can be located. And already in the 9th century, there was a first description of measles in a book by a Persian physician, the Book of Smallpox and Measles, distinguishing these two diseases. Not before the 18th century, it was demonstrated that measles is caused by an infectious agent in the blood of patients. And finally, it's worth noting that between the mid of the 19th century and 2005, measles is estimated to have killed about 200 million people worldwide. And we start to have data, really data from the United States from 1912, when measles became a notifiable disease. And in the following years, we had 6,000 measles-related deaths reported each year only in the United States. Why the year 1963? In 1963, the first live attenuated measles vaccine was introduced. Before its widespread vaccination introduction into the vaccination scene, almost all children developed measles, and in major epidemics, which occurred every 2 to 3 years, an estimated 2.6 million deaths worldwide occurred each year. Measles in 2000, after intensive vaccination campaigns, was declared eliminated from the US, and we will see how this developed further. The same year, there were 800,000 measles deaths worldwide. This was followed by accelerated immunization activities by different countries, WHO, a partnership, measles rubella partnership, which was formerly called Measles and Rubella Initiative over 25 years now, which had effects, but not exactly what we had hoped for. The coverage with the first measles vaccine dose, and we know we need 2 of them, remained at 83% worldwide, particularly low in low and middle income countries, fragile settings. The estimated measles cases increased by 20%, and the number of countries affected by outbreaks also increased from 36 to 57. This is a sign how, gives you the impression how the awareness of measles is in the press and in the public. When you know exactly, you remember probably that in the years 2018-20, there was this Ebola outbreak mainly in the Democratic Republic of Congo, with over 2,000 people dead. But nobody noticed it actually during this time. There were 3 times more deaths from measles in the same period. But there was good news. Since 1974, this is when measles vaccine was really well introduced, there were almost 100 million lives saved by the vaccine. And we saw a dramatic reduction in cases worldwide with increasing coverage with the vaccine. You see 2 lines. The black line is the first dose, the blue line is the second dose of the vaccine, and we all know it's required to have 95% of vaccination rate to really eliminate measles. We are rather far from that, as you can see, worldwide, and even with a decrease in the last years. So this is the current situation, more or less, a snapshot of the year 2023, with 10 million cases and 100,000 deaths. Most of the lethal cases were under 5 years. And with this in mind, before I go to come to the European situation, I would like to get back to the facts. What is measles? I think I don't have to tell you a lot about that. You're all experts. The pathogen is a single-stranded RNA virus. There are genotypes, groups after this molecular diagnosis. We can follow the endemics and the infections. It's actually good luck that we have a low mutation rate in this virus, so it gives us the chance to have a persistently active vaccine. But the transmission is via droplets, incubation period around 10 days. Prodromal period is rather long, with high fever, with runny nose, with dry cough, with conjunctivitis, very characteristic coptic spots, you all know, and the typical measles exanthem, which can be partly hemorrhagic, is maculopapular, and typically starts on the head, mostly behind the ears, with a dissemination from head to feet. The symptom peak is mostly on the second, third day of exanthema. Thereafter, we have rapid improvement of the disease. Particular challenge is to recognize the measles rash in dark skin. This was reason for actually a publication in Medscape, a discussion in Medscape, and should really be trained to be able to recognize. Measles is very contagious. We know droplet infection, the human-to-human transmission opens the option to eliminate and even eradicate measles, as it has been done with smallpox. It could be done with polio. The entry is via the upper respiratory tract in the eyes. And the bad thing is that the highest risk of infection is actually in the 4 days prior to onset of exanthema. Nobody knows that this is actually becoming measles, and the infection risk lasts 4 days thereafter. Even with a very short contact, one index case can infect 12 to 18 other people in a, of course, theoretically fully susceptible environment, and almost everybody who was infected also gets the disease. And that's something that really has to be kept in mind for practical reasons. In Rome, where the index case has left, when the index case has left more than 2 hours, the room can still be infectious. I had a patient myself whom I'm now caring for, where the parents said we don't need to have there was the conclusion that there was no need of giving passive immunization to this patient because it was more than 2 hours that this patient received or got measles. It was a baby, which was particularly bad. So is it? There's very often actually measles is conferred as or conceived as a mild disease. We have to have measles. Some people say to develop our personality. Let's see how the truth is looking like. We have complications in 20 to 30%. Pneumonia in 1% actually is a major cause of death worldwide. Diarrhea through to dehydration is a particular problem in developing countries. Otitis, very often seizures, encephalitis, 1 in 1,000, and an average 1 in 1,000 deaths with a very wide range depending on where the patient lives and which medical settings are available. I don't have to tell you about subacute sclerosing panencephalitis, which becomes more and more probable the younger the child is when it gets the disease. T-cell deficiency is a particular problem. Patients with leukemia, HIV, with pneumonia, severe, mostly lethal pneumonia with inclusion body encephalitis, and the disease often occurs without exanthemas, white measles. And infants are particularly prone to a milder course on the one hand, but they have the highest probability of encephalitis and later SSPE, with 1 in 500, which is a real fear of every mother whose baby got measles and is now waiting for 10 years if this child develops this SSPE. For parents who refuse to have their children vaccinated against measles, it's maybe recommendable to watch YouTube videos of mothers of SSP patients, which may change their mind. Immunosuppression is something that induced by measles is something that is relatively recent knowledge, about 5 to 10 years. On the one hand, we have known for a long time that T-cell deficiency, sorry for the misprint, is lasting for 2 months, like AIDS. It's like AIDS. If you have a positive skin test for tuberculosis, for example, this turns negative for 2 months. And this is a very short period, so mostly patients are cared for, so they will not happen a lot, and you won't see clinical consequences. But there's also a loss of B-cell memory, and this is recent, which can last up to 3 years and leads to a long-term immune amnesia with higher, really measurable high mortality by various infectious diseases. And this has not only been observed in the third world countries, but also in Denmark, in the industrial. Risk factors for complications and deaths, particular risk factors beside of age and immunodeficiency, is poor nutritional status, and is also vitamin A deficiency. These are, let's say, features that are particularly important for the third world, where we see corneal scarring, blindness due to vitamin A deficiency, in connection with measles. How differently the burden of disease and the awareness of disease in the world is reflected by these press releases. There's one from 2019 showing that almost 1,000 Madagascar children had died in the few months before this press release due to measles. And 5 days later, there was a press release from the same agency that posted a measles outbreak in Canada affecting 9 children, or 9 people. So there were 9 cases that were reported with the same intensity. So this should reflect how differently measles are actually perceived in the world. So during the pandemic, we had the observation that measles, which had increased enormously in the years before, up to almost 105,000 cases with 64 deaths in the year 2019. During the pandemic, there was a dramatic decrease in all infectious diseases. Actually, as you all know, conferred by our protection measures that we took against COVID-19. But at the same time, there was also a further the decrease of MMR vaccine coverage with 2 doses, and the WHO drew the conclusion then that this is a big problem. They reported about 40 million children susceptible to measles threat in the year 2022. And this is the situation now in Europe. The measles cases that were virtually disappeared in 2021-22 rose to 60,000 in 23, 127,000 more than that in 2024, which was the highest number since 1996 or so. This was actually predicted, and it's the problem we are currently fighting. If you analyze the ages of the affected patients, this is, as always, particularly affected are small children, or the young children up to 5 years of age. And then again, the group I can't show you it. The group over 30, so young adults, which makes up a considerable amount of the affected patients. And what's really sad to report, these are numbers from Austria, sorry, that this column contains a considerable amount of healthcare workers, which should actually protect and not infect their patients, and on the other hand should be a role model instead of being susceptible themselves. So there's also a focus of action. In all of the European region, there were almost 60% of patients hospitalized, and we had 38 measles-related deaths in 7 countries, which are listed here. The most affected countries were Romania, and you see Kazakhstan, Russian Federation, and down to Italy as the first next European Union country, and more, of course. And in this other group of 6,700, I always I'm embarrassed to say that Austria, my home country, is playing a leading role. Fifth, number 5 within Europe, let's say within the European Union, with 555 cases, which is almost the same number that Germany had, which is 10 times bigger and almost twice as much as the United States of America had in 2024. If we have a look over the Atlantic and see the country which had been declared eliminated from measles in 2000, as you remember, this elimination status is really under threat. If you see what happened in this year, you heard the reports from Texas mainly and other states in the United States that was meanwhile 712 cases this year only, all with most of them unvaccinated and 11% hospitalized, and already 3 days. 2 school-age children and 1 case that has to be yet to be confirmed. Yesterday's news brought this article showing that the cuts of the for the health budget by the current American government led to closure of vaccine clinics, dozens of vaccine clinics in several states, also in Texas, which is mostly affected. Yeah, let's come to the chance how to get this problem under control. What can we do about immunization? And let me again start with a little historic view back. Around 1970, 66 to 76, there was an inactivated vaccine, which was with the name quintovirilon, which had hardly any immunogenicity. Immunity rapidly waned, and these patients were not protected for a long term, and it's recommended, of course, to have these patients vaccinated twice with a live vaccine. As you already know, 63, the attenuated live vaccine was introduced, which was highly protective with 99%, about 99% protection after the second dose, conferring lifelong immunity. These vaccines are available in all 53 countries of the European Union, European region. There's a 2-dose schedule ranging from 9+ months of age. We'll have a look on the European schedules. And there is a WHO recommendation when there are high-risk settings, like outbreaks. Then MMR vaccination is possible from 6 months of age. But in this case, 2 further MMR doses should be given according to the national schedule. If you have a look on the vaccine schedule from ECDC, you see that the first vaccine is recommended mostly around 1 year of age. Some, like Austria, in a desperate attempt to get the situation under control, starts with 9 months of age. Others, like Sweden, with 18 months of age, which is very late, leaving the children susceptible, particularly in the time when they are most prone to severe disease and later SSP. So adverse events are limited to vaccine measles, should be communicated, of course, to the parents. Vaccine measles only fever and or rash, which occurs 5 to 15 days after vaccination, which is non-contagious, not dangerous. Febrile convulsions can occur without sequelae. Transient thrombocytopenia in a frequency of up to 1 to 30,000, 50,000, but measles has this complication with 1 to 3,000, 10 times more. There's rarely a mild reversible arthritis, but due to the rubella component. And meningitis, encephalitis, anaphylaxis is in the range of 1 to 100,000, 1 to 1 million. There is no causal relation between MMR vaccination and autism, allergies, or inflammatory bowel disease, as has been falsely stated as you all know, by a colleague who is not a colleague anymore because of the scientific fraud he made by this wrong course, retracted publication. This evidence, counter evidence, is based on almost 15 million vaccines. Contraindications: infants under 6 months, 3 months after IVIG treatment, immunodeficiency, anaphylaxis, and pregnancy. Theoretical reasons. I just want to go very shortly on the first and last point. So what's the reason why we don't vaccinate before 6 months of age? Maternal measles antibodies are circulating in these children for more shorter or longer time, which is shown in this graph and this investigation that shows that we can only count on protection, on nest protection by the mother up to about 3 months of age. At the 6 months of age, mostly the maternal antibodies are waned. This depends also on the fact if the mother had measles or was vaccinated against measles. After measles, of the mothers who had measles confer a longer protection, longer lasting protective levels of antibodies than vaccinated mothers. And so more and more vaccinated mothers are now giving birth to babies. And so we can start vaccination earlier and earlier without the risk that the live vaccine is killed by maternal antibodies. So, and vaccination during pregnancy, of course, we know that is live vaccination is not indicated in pregnant women, but after accidental vaccination of pregnant women, there were no negative effects on fetuses shown and reported. And regarding rubella, there's a special big, let's say, natural trial in Brazil. There were a national immunization days. Everybody was vaccinated against rubella, measles, mumps, rubella, and of course there were many women that were not aware that they were in early pregnancy, and none of these women developed or gave birth to a child with congenital rubella syndrome. So there's actually no danger coming from there. So accidental MMR vaccination in pregnancy is definitely no indication for abortion, and there's no reason to test a woman to vaccination for pregnancy. And also regarding breastfeeding, there's always the fear that vaccine virus can be excreted through breast milk and transferred to the baby. This is actually shown for rubella and yellow fever, but only for yellow fever. There were few reports with transient symptoms of yellow fever in the children. So the conclusion is that basically all inactivated and live vaccines can be administered to lactating mothers. In yellow fever vaccine, of course, there has to be strict indication. And for seronegative breastfeeding mothers after birth, MMR and varicella vaccinations are really urgently recommended. I go quickly through that there are, of course, we mentioned that before, initiatives all over the world to improve the situation. This Measles Rubella partnership by American Red Cross and several stakeholders with CDC and Gavi and also under UNICEF and WHO umbrella have the aim that no child dies from measles anymore or is born with congenital rubella syndrome anymore. It's a very good aim and goal, and but still there has to be a long way to go to achieve this. This global measles and rubella laboratory network is similar to the influenza network, looking for timely diagnosis, following the measles strains all over the world, and tracking it and giving good data to countries in order to get rid of the disease, actually. Yeah, measles is so important that it is used actually as a tracer of the health system's ability to deliver essential childhood vaccines. Measles is vaccinated, mostly the other vaccines are also administered. We are asked by WHO to use every opportunity for vaccination, check the vaccination record at every visit, and also prior to kindergarten, school, and so on. Use pre-travel consulting, use reminder systems, mass vaccination campaigns, train healthcare staff, vaccinated it, and all physicians should be eligible to vaccinate, actually. So that adults should be vaccinated by pediatricians, partners, by mothers, by gynecologists. Before the pandemic, the vaccine hesitancy was already listed under the 10 threats to global health. You know all about the infodemic, the many fake news into people hesitant, becoming hesitant not only versus COVID vaccines, but to all vaccines. And we are asked to communicate and to convince our patients to use the probably most effective measure we have to protect children, to protect patients from severe disease, from deaths, from lifelong problems. I go over this. We should use true stories, not the wrong stories like fake news. And one of the stories is that even a common cold should prevent us from MMR vaccination. We see that it doesn't matter if a child is a little bit sick. It even has the advantage of a better seroconversion rate, as you see here with the equal tolerability. This was a visit to Austria by the WHO team, led by Mark Muscat, and I have to say thank you very much at this moment that he provided me with all the data, the new data that were published right now in the EPI brief. So I can close, and thank you very much for your attention. The view from Cyprus, where the next speaker is coming from. Thank you.
Thank you so much, Hans Jürgen, for such an amazing presentation on a truly important topic. Time is running, so we'll save the questions until the end, and we'll just hand over to Zoe right now.
So good evening also from my side. First of all, I would like to sincerely thank Professor Kolensko for his kind introduction, and of course to welcome you all to join us during this EIP webinar. I will try to share my screen 1 second. Can you see my screen?
Yes, we can.
Thank you very much. And after this excellent presentation of Hans, we will proceed now with pertussis, focusing again on vaccination and prevention. And actually, I think that most of us, we were informed that, especially after the COVID-19 pandemic, there were increasing trends of pertussis cases globally, but also, of course, in Europe. There was a significant report launched on May 2024 by ECDC, informing us that we present currently a tenfold rise in pertussis cases. And of course, there were, let's say, increased interest also from media with regards to this topic. You can see a few, let's say, articles related with that. I would like to start with an introduction again to pertussis and the main points that we need to keep in mind. First of all, pertussis or whooping cough is caused by Bordetella pertussis and has plagued humans for at least 800 years. We all know that pertussis is highly infectious and can be unfortunately fatal in the unvaccinated and especially in very young infants below 6 months of age. Pertussis is also an endemic disease, both for the European area, but also worldwide. And according to ECDC, every 3 to 5 years, it is expected to have larger epidemics attributed to pertussis, even with high vaccination coverage. And unfortunately, today, still, pertussis accounts for almost 161,000 annual deaths and is a leading cause of childhood mortality owing to a vaccine-preventable disease. Now, when it comes to diagnosis and symptoms, the diagnosis of pertussis is based primarily on clinical symptoms, but also on laboratory tests. The severity of symptoms depends, first of all, on the age of the patient, and you can see on the slide a very characteristic clinical picture of a pertussis infant case in an NICU, the strength of the immune response, and the degree of systemic transmission of the bacteria. The average incubation period spans between 7 to 10 days, and the disease course can last up to 3 months. Now, when it comes to the classic pertussis disease, it is divided, as we know, in 3 stages. The first one is the catarrhal stage with mild respiratory symptoms, very similar to those of common cold, for approximately a duration of 2 weeks. Then we have the paroxysmal stage, which is actually the hallmark stage with paroxysmal cough and a large amount of mucus and sputum in the trachea, which can span for a period of 4 to 6 weeks. And finally, we have the convalescence stage where cough significantly reduces until cough and vomiting disappears gradually. But of course, pertussis is also associated with complications, primarily related, of course, with the respiratory system, like pneumonia, emphysema, pneumothorax, lung atelectasia, pulmonary arterial hypertension, of course, cough that we mentioned, and in fewer cases, encephalopathy. And when it comes to symptomatology, please keep in mind that adolescents and adults less often present with the classic symptoms of pertussis because they're usually milder, in some cases also asymptomatic. And this is also very important, and we will discuss it later, also for assessing the burden of the disease in seroepidemiological studies. Now, when it comes to the transmission and the pathogenesis of pertussis, transmission most commonly occurs from human to human via contact with infectious airborne respiratory droplets from cough or sneeze, and requires repeated or prolonged exposure and or close contact. With regards now to the attack rates for non-immune contacts in the household setting, it has been estimated at up to 90%. And now with regards to the pathogenesis of pertussis, it is not 100% or completely understood, but the disease appears to be mainly toxin-driven. So Bordetella pertussis creates various biologically active and antigenic products, including filamentous hematoagglutinin, FHA, pertactin, PRN, and pertussis toxin, PT. So these toxins are released, and when bacteria attach to cilia of the respiratory system, they're paralyzing the cilia and they cause inflammation of the respiratory tract. And clearance of pulmonary secretions is subsequently impeded, leading to the classic symptoms of pertussis with the paroxysms of cough. So cases are not considered infectious after having 5 days of treatment with a macrolide or 21 days after the onset of cough, if no treatment. And treatment with macrolide should be given as early as possible, even if feasible before the paroxysmal phase, because in that sense, it can reduce both the symptoms, but also the severity of the disease. Otherwise, treatment also assists in reducing the risk of transmission. Now, when it comes to the diagnosis, of course, we have several diagnostic methods, starting with the blood routine test and the peripheral blood smears that, of course, they're not pathognomonic, but they are indicative, showing lymphocytosis and deeply clefted lymphocytes. Bacterial cultures, of course, remain the gold standard. Serum assays with PT-IG titers are very important also for the conduct of seroepidemiological testing and studies. And of course, PCR testing is of course of importance, and it can provide us also with more information, especially nowadays that we need to have also information with regards to resistant strains. What is most importantly to know is that the optimal timing for pertussis diagnostic testing depend on the stage of the disease. So if you see also the slide, culture is indicated at the early stages of the disease, let's say the first stage, similarly with PCR that can be also expanded up to 4 weeks. But then we can actually select from week 2 to week 8 serology and onwards. But of course, after that period, we need to interpret the results the serological results with cautions, because we have also in studies to differentiate between immunization and infection if we proceed with seroepidemiological studies. Now, there are also a lot of information regarding the differential immune response to natural Bordetella pertussis infection and immunization, either with whole cell or acellular vaccines. So generally speaking, antibody produced through vaccination could persist for a period spanning from 4 to 12 years, while immunity gained through natural infection could persist up to 20 years. There are significant, let's say, differences between the immunity caused by the whole and the acellular pertussis vaccines. And first of all, the whole vaccine induces cellular immunity dominated by Th1 and Th17 cells, whereas the acellular vaccine induces cellular immunity dominated by Th2 and Th17 cells. So during the protective immunity after Bordetella pertussis infection, we do know that Th1 cells exert a dominant effect, while T2 cells are dispensable. So what we know also is that after a whole pertussis vaccine, the memory T cells residing in the nasopharynx and lungs rapidly proliferate and secrete also IgA upon stimulation with Bordetella pertussis, exerting a protective effect against nasal colonization, which is, as we will see also later on, very important also for infection and transmission. Now, when it comes to late-stage preventive measures against pertussis, we have 3 pillars: controlling infectious sources, blocking transmission routes, and protecting susceptible population. When it comes to controlling infectious sources, of course, we need to further strengthen surveillance of the population. When it comes to blocking transmission routes, as we have to deal with a respiratory induced infection, of course, we need to wear masks, respiratory etiquette, keep social distances, and pay attention on ventilation, protecting susceptible population, of course, taking prophylactic medication if needed. The most important part that we will discuss also later, receiving immunization and most importantly, booster immunization. Of course, optimizing and accelerating our vaccine strategies, overcoming resistant rates, and refining, last but not least, vaccination programs. And since we are discussing about resistance, you all know about the recent plague of antimicrobial resistance. Unfortunately, this is evident also for Bordetella pertussis. And this is a very nice, actually, review paper that was published in Lancet Regional Health in 2021, trying to analyze the percentage of macrolide-resistant Bordetella pertussis worldwide, which is mainly attributed to one mutation in the 23S rRNA gene. So fortunately, until now, worldwide, the resistance rates to macrolides are probably very low. But on the contrary, as you see on the slide, in China and in areas nearby China, the resistant rates are ironically very, very high, reaching 70 to 100%. And of course, this is concerning because we lived in an interconnected world, and due to globalization, there is increasing concerns that these resistant rates might also increase in other places. In that case, whenever we have a resistant strain identified, we have to know also the treatment options. Sulfamethoxazole trimethoprim remains effective and can be used for patients aged above 2 months of age, and piperacillin tazobactam is recommended for infants below 2 months of age. Now, when it comes to data and research and investment, unfortunately, currently there are only 2 consortia that are focused on Bordetella pertussis and resistant rates, GPI, Global Pertussis Initiative, and Periscope Pertussis Correlates of Protection Europe, which is an IHI project. And this project is also very important because there has been several discussions if we need a new pertussis vaccine. Of course, we always want to improve our vaccination armamentarium. And the problem actually with the current vaccines, and especially with the acellular vaccine, is that the immunity is short-lived, much shorter than the whole cell vaccines. And there are several studies, like the one that is depicted on this slide, showing that the effectiveness of cellular vaccines in 0 to 10 years old is reduced from 99% in the first year to 81% 5 years after vaccination. And for the ages 11 to 20 years old, it dropped from 72 in the first year to 42% from years post-vaccination, 4 years post-vaccination. And of course, there is an increasing, let's say, interest and investment for a new vaccine among them. As I just said, Periscope Consortium is trying to accelerate the development of a new pertussis vaccine, which is a nasal vaccine, in order actually to induce also local or nasal immunity in order to reduce the risk of transmission and infection. And now when it comes to updated data of pertussis epidemiology, evolutions, and vaccines, I would highly recommend you to read this review article in Nature, which was published last year. And I would try to summarize most of the important, let's say, results from their global analysis. You see here on the slide the global recommended vaccination age for the primary course and boosters for the period to 2015 to 2019. And you see on the from the one side the recommended vaccination age for the primary course according to the income group, and actually you can see the stratification of the income groups from 1, low-income countries, to 4, which is high-income countries. And what we can see is that we see a significant heterogeneous vaccine policy and implementation, with higher income countries recommending later vaccinations for the primary series in infants. And on the other side, we see the proportion of geographical areas, again, using Tdap vaccines for primary immunization, implementing also additional vaccine boosters. And what we can see here is actually, again, heterogeneous vaccine policy, with higher income countries recommending more boosters in older age groups. And we move forward to this global map, which is a global map of average diphtheria, tetanus, toxoid, and pertussis coverage during the same time period, with red color indicating Tdap vaccines and blue colors indicating the diphtheria, tetanus, and whole cell pertussis vaccines, and of course also the different, let's say, income areas. What we can actually result from this, let's say, graph is the box plot, where you can see, again, heterogeneous vaccine policy with higher income countries achieving higher DTP3 coverage. And this is something to keep in mind. When it comes now to the global pertussis cases and global coverage for DTP3, what we can see for China, US, UK, and Australia is the increasing actually trends for the last few years, while for the coverage, of course, with blue color, it is China which has achieved a constant, let's say, high level of DTP3 vaccination. And for the other, let's say, continents and countries, we see some differences that we will discuss later on. And of course, we would like also to focus on Europe. And therefore, I would like to summarize some of the pertussis epidemiological data that were summarized in the latest ECDC report in 2024. So as you can see, after a few years of limited circulation in Europe, particularly during the COVID-19 pandemic, more than 25,000 cases of pertussis were reported in the broader European area in 2023. And more than 32,000 cases between January and March 2024. So again, as we know and as we said, infants, especially small infants below 6 months of age, are largely affected, and they, let's say, are associated with a majority of deaths, unfortunately, also in Europe. But what is also important to emphasize for Europe is that these surveillance data that we will see also in the following slides need to be interpreted with caution due to known differences in member states when it comes to their surveillance systems, their availability of laboratory methods, the testing practices, as well as their vaccination schedules. And this is something that we need to keep in mind when we interpreted the data and the observational epidemiological picture. Now, when it comes to the risk assessment, As you can see, for the risk for infants below 6 months of age is very high. For infants above 6 months of age and older is moderate, and this is also the case for older adolescents and older adults. Now, when it comes to the number of pertussis cases by month and age from 2011 to 2024, I think this graph is very obvious, indicating what happened during the COVID-19 pandemic and what is happening after 2023 and especially 2024, with significant increasing cases all over Europe. And what is mentioned clearly also in this ECDC report for the pertussis cases per 100,000 population by age group and year is that we have increasing trends, not only now in younger children, but also in older children, and some increasing trends also for the elderly population, which is visible also in this slide. Now, when it comes to the number of pertussis deaths, again, the same time period, 2011 to 2024 by age group and year, again, the same as we know, unfortunately, younger infants below 1 year of age are the mostly affected, following by elderly population above 60 years of age, especially when they have additional comorbidities. Now, if we move forward to the pertussis vaccination program, this is really very interesting to see the significant differences when it comes to the design and the implementation, both for the infant program, I mean the type of primary schedule, including the first booster, 2+1 or 3+1, the age of the third dose. Very interesting to see significant differences when it comes to the boosters, but also differences when it comes to the adult program. You can see that some European countries recommend boostering every 10 years, some other countries 1 booster in adulthood, and so on. So this is something for us to be further discussed. Now, some more data with regards to the vaccination coverage of the third dose of diphtheria, tetanus, pertussis in 2022. This is the landscape, actually, and the different colors reflect the different vaccine coverage. But most importantly, I would like you to focus on the graph, which is again from 2012 till 2022, the median vaccination coverage. And what we can see is that we have a slightly decreasing trend, starting with 97% in 2012 and coming now to 94% in 2022. Similarly, for the vaccination coverage for DTP4, the MAP, and most importantly, the median vaccination coverage, again, similar observations. In 2018, we had 91.1% vaccination coverage in Europe, and currently we have a decreasing trend of 89.7% in 2022, something that we need to keep in mind. Together with that, and this is another topic that we need to emphasize as pediatricians and as healthcare providers in general, is the vaccination coverage of pertussis in pregnant women. So until now, few countries have provided data with regards to their strategies and the vaccination coverage. And as you can see from the 9 countries that have already reported the data to ECDC, it has been observed a significant range from 1.6 to 88.5% when it comes to pertussis vaccination during pregnancy. And of course, I would like to remind you that the current recommendation is to give a single dose of Tdap in every pregnancy, preferably during the early part of gestational weeks between 27 through 36 weeks. Since we are discussing about vaccination in pregnancy, just to mention that we need to keep in mind effective strategies of communication. Hans also emphasized about vaccination and vaccine confidence. This is a global project entitled Vaccine Confidence Project, and they have published several, let's say, studies, including this one in 2018, how to improve actually the vaccination in pregnancy, starting with information and education. for the patients, the mothers, staff education and training, and of course, health system improvements, and happy to discuss it later on if we have time. Now, to sum up the causes of pertussis resurgence during the last year, of course, it is multifactorial. It is mentioned also in the latest ECDC report. Number one is the immunity that is obtained through pertussis. Unfortunately, it declines over time, so we have to deal with waning immunity. The application in many countries, especially in Europe, of DTaP, and as we said, there are differences when it comes to the immune response. Co-purification processes that may also play a role. Booster vaccines that we discussed, both for adolescents, but now also for maternal vaccines, and of course, further optimization of our vaccine schedules. Now, other factors, gene variation, we discussed about the evolution of resistant strains and other strains, monitoring our capabilities, very important part, and of course, also the susceptible host we will have, and we have aging population with comorbidities that might have an impact also on pertussis severe infections in the future. And closing my presentation, I think it's very important for all of us to keep in mind the ECDC recommendation on how to move forward when it comes to pertussis national, but also regional, subnational programs. So the primary aim is, of course, timely and full completion of primary immunization series and subsequent booster dose. Please keep that in mind. We need to keep continuously high, let's say, coverage above 90%. Please focus on maternal vaccination. It's a highly effective approach in order to prevent disease and death in infants, and we can discuss it also later on. Since we have seen a shift in recent years towards adolescents and adults, of course, boostering in adulthood and in an adolescent period is something that we need to further promote and discuss, and of course, to further improve our capacity and standardization when it comes to surveillance of these important diseases. And last but not least, please, again, I would like to emphasize that we need to discuss with all stakeholders how to strengthen and harmonize disease surveillance and early disease detection and control of pertussis, but also for other diseases. This is very important, and I think there is a lot of place for improvement. We will give you the slides in order to read it whenever you wish, when it's recommended. And last but not least, I would like, first of all, to thank you for your attendance. And since lately there has been a vivid discussion when it comes to vaccination and adverse events, actually for the anti-vaxxers, I would like to consider Aristotle, since I'm Greek, prevention is always better than cure, and vaccines are still the strongest preventive weapon against infections and, of course, against pertussis. So thank you very much.
Thank you, Zoe. This was an amazing presentation. I appreciate how much new information you brought in and shared. And I think you woke everybody up with making us aware how much preventable harm there's out there and how much more we need to do. So let's move to the questions. We have some questions already in the online tool. So the first one is for you, Hans-Jürgen. I think the first one you answered already in your presentation, which is, can we give measles vaccines before the age of 6 months? And the second question is interesting. Can we vaccinate once the child is already attacked by measles?
Oh, yes. I think I don't have to answer anymore. The maternal antibodies that are waning over the first months of life of a child are, let's say, destroying the live vaccine if you vaccinate too early. So 6 months is currently obviously the earliest time that we can safely administer the vaccine. Unless the mother had measles before, there might still be antibodies on. The second question, help me again, was...
Can we vaccinate a child that already has measles?
So there's, of course, the post-exposition prophylaxis that is recommended. So if there is an infection, there is a contact with a measles case on the time when the measles rash is occurring, it is recommended to give post-exposition prophylaxis if the patient is eligible to get active immunization. There's no contraindication like in small babies, immunosuppressed and so on. In this case, you have to give immunoglobulin. But the post-exposition prophylaxis can be given safely up to 72 hours to 3 days after the contact, with a very high chance to prevent the occurrence of measles in this patient. You can give it later on, it's not dangerous, but the effectiveness already is lower. Up to
Great, very clear advice. The next question is coming from Dr. Vahidi from Dubai. Very welcome. We're very happy that you join us from UAE, and please share it with your colleagues. The activities of the European Academy of Pediatrics are obviously open to all our colleagues wherever you are. And his question is regarding autism and autism spectrum disorders, regarding the possible relation with measles vaccination. He says, in my practice, I encounter many parents who refuse vaccinations, including the measles vaccines, due to fear of a link with autism. Could you kindly address the scientific evidence on this issue to help us guide and reassure families more effectively? And maybe I might add, I've been reading now that the new Minister of Health in the US has announced that he wants to look into autism and the causes. I'm not sure how much disinformation will appear there again. So it's worrisome.
So it's actually incredible how this fake news that has been published in the 90s by Mr. Wakefield, who is not doctor anymore, as I told you before, is still prevalent and still affecting the minds of so many people. So it's actually back to the evidence. So there was a fraudulent paper paid by lawyers that tried to get money from the industry, for patients with autism or with inflammatory bowel disease, and there was the attempt to link these patients or these cases to the measles, mumps, rubella vaccine. This patient was published by the Lancet, but the Lancet retracted this publication after this evidence could not be repeated, could not be replicated. And it was shown thereafter, as I showed you, in 15 million children, vaccinees, that there is no evidence whatsoever between measles vaccine and autism. It's actually recommended by a communication scientist who did a lot of studies on how to communicate vaccination to people, and not to mention autism anymore, as a possible side effect. Because if you say to a mother, see, measles vaccine doesn't cause autism, she will be that preoccupied that she takes away measles vaccine, autism, links it anyway further on. So it should be avoided to directly address this in the discussion. And let's talk about other things, that's better. But in the scientific community, it should be clear, meanwhile, that this was a fraudulent attempt, and the author was punished. He is not living in England anymore, and can't work as a physician anymore.
So I was very impressed, I must say, by a comment by Professor Susan Sachs at the last European Academy of Pediatrics Congress. She's a professor in communication science, and she advised we should stand up clearly and say to our families, we are the experts, we know all the evidence, we strongly recommend you to vaccinate, and if I vaccinated my children, or I will vaccinate my children, that would be the really strongest impact we could make, not discuss all the data which leads to nowhere, but just give a very strong statement. We know we are the experts. We recommend that you should vaccinate. Anyway, let's go to the next question, which is by Sabona Bayesa. And it's to you, Zoe. How can we treat children with pertussis having associated leukemoid reactions?
Thank you very much for this interesting question. So actually, leukemoid reaction, first of all, we have to emphasize that it's very, very rare, and it's associated with increased white blood cell count. So this situation, of course, can lead to hyperviscosity, pulmonary hypertension. It might contribute actually to shock or respiratory failure. And I'm saying that because, of course, we can manage it, but definitely we need to hospitalize the child in order to receive, in a way, expert help. First of all, apart from the obvious treatment with antibiotics, it needs actually respiratory support, it needs fluids, hydration, electrolyte balance. What I want to say is something that you need to, of course, take care in a hospitalized setting, and of course with experts that will need to, in a way, control and balance the situation apart from the infection. Very rare again, but thanks for mentioning. Personally, I didn't have experience with such a case. I don't know if Hans or anyone from the panel had a similar experience with lymphocytosis after pertussis, worsening lymphocytes.
Unfortunately, we had a case a year ago with exactly that complication that died on ECMO. It was the first case for 20 years, I think, that we had a dead child from pertussis.
Okay. And then we have one more question. Julia Balzeviciene, if I pronounce it correctly, sorry if I don't. Also, thanks you for the wonderful presentations. And she has a question for patients with allergy. If the child had an anaphylaxis caused by egg white, no reaction after the first MMR vaccine, is there a contradiction to a second MMR vaccine?
So if there was an anaphylactic reaction to the MMR vaccine, of course, this is a contraindication to give another MMR vaccine. But egg white is no per se. Egg white allergy per se is not a contraindication for MMR vaccination anymore. It was pulled out of the product information, actually, was removed. Formerly, there was a contraindication in also in tick-borne encephalitis and influenza vaccines and MMR. This was definitely removed. So egg white allergy per se is not a contraindication to give MMR vaccine. But if you had anaphylaxis after receiving a first MMR vaccine, this might be to another component. Yeah, and of course, then you shouldn't give the same vaccine again.
And then we have one more question by Emisa Clement, who also thanks you for the amazing presentations. She asked whether women should vaccinate before pregnancy against pertussis, or whether it's more effective during pregnancy. Zoe.
So thank you very much. Again, I will emphasize the recommendations. Ideally, we would like to get the vaccine during the pregnancy, and ideally during the 27th and 36th week of gestation. And this timing actually is appropriate in order to allow the mother to produce antibodies that are then passed to the baby through the placenta, offering early protection against pertussis before the baby can be vaccinated by themselves. So this is the recommendations. And of course, again, we would like to emphasize that vaccination should be done for every pregnancy, actually. There were also other, let's say, strategies in order to protect younger infants, started with cocooning or vaccination of, let's say, the closer environment. But I think that based on the current evidence, the most effective, let's say, method to protect young babies and infants below 6 months of age is vaccination during pregnancy for the period that I mentioned.
Thank you so much. We are running slightly late, but I'll take one more question because I think it's really interesting from Irina Guriuch. I'm sorry. Also, thanks for the presentation. Do we need to administer further detailed vaccines for children who had pertussis already and MMR for children who had measles?
I didn't understand the question, I have to admit, I'm sorry.
Should we administer further detailed vaccines for children who had pertussis already and further MMR for children who already had measles?
I think obvious, yes. I mean, sorry, Hans, yes, please.
Sure, you.
No, I'm fine, yeah.
Please go ahead. Sorry.
Ladies first, come on.
Definitely, we need to proceed, actually, and this is also something that we need to discuss with regards to boostering of children, bearing in mind that the waning immunity that we already mentioned. So this is something that we definitely need to proceed.
Great. Thank you so much for these wonderful presentations and the great discussions. I would like to also thank all the participants. I'm impressed how many of you joined this evening. And thank you for your participation, for your excellent questions. Join us again in May for our next webinar on alcohol. You may know that Europe is the continent with the highest per capita alcohol consumption among all of the world regions. And we know it has dangers for children, particularly in early childhood. So Anne de Gurtenere will address it. I'm sure it's going to be an excellent event. And don't forget to go back to our website, EAP Pediatrics, and look what more the European Academy has to offer, not the least our exciting European Academy of Pediatrics Annual Congress and Master Course, October 16 to 19, 2025 in the capital of Poland, Warsaw. Thank you again, everybody, and have a very good evening.